All right, we're going to go ahead and get started. Welcome everyone to CVSA's September virtual presentation, Auricular Neurostimulation Therapy for Pediatric CVS, Update on Current Research. Before I introduce our speaker, I want to introduce myself. My name is Debbie Conklin. If you've contacted the office in the last 4 years, you have talked to me as I have been the program director since June of 2016. My involvement with CVSA started with organizing the Run for the Bucket shortly after my son's CVS diagnosis in 2005. In 2007, I joined the CVSA Board of Directors, and in 2016, I became the program director. Now, for just a little bit of housekeeping for the virtual presentation. During the presentation, you'll all be muted. Please do not unmute yourself as background noise is distracting to both the speaker and those attending. If you're not muted, we will ask you to mute yourself. Please also do not use your own recording device during this presentation. We are recording it for later viewing on our YouTube channel. If you're having trouble with your audio, you may consider using your phone to call in instead of using your computer speaker. We have about 150 people on this meeting, so unfortunately that means we may not have enough time to get to everyone's questions, but we will of course do our best. You can just submit your question right in the chat box at any time during the presentation, and we will go through asking them to Dr. Kovacic at the end. And now for the main attraction. We would like to welcome Dr. Katja Kovacic as this month's presenter. Dr. Kovacic is an Associate Professor of Pediatrics in the Pediatric Neurogastroenterology, Motility and Autonomic Disorders Program at the Medical College of Wisconsin. She serves as the Director of Pediatric GI Motility and Cyclic Vomiting Syndrome programs. Through the CVS program, she evaluates complex nausea and vomiting disorders referred from the US and internationally. Dr. Kovacic has received numerous research awards and serves as a medical advisor to CVSA. Dr. Kovacic is active in clinical research with focus on pediatric nausea and vomiting disorders. She has also established a non-invasive auricular neurostimulation program and directs a multi-center registry using this therapy. This is what she will be sharing with us today. In her spare time, Dr. Kovacic is an accomplished tennis player as well. She is from a small autonomous island in Finland, the population smaller than San Diego University, which is actually where she went to go play college tennis. On a personal note, the first time I met Dr. Kovacic and saw how happy she was to be helping so many people at one time during the Date with the Doctor at the biannual CVSA conference, I knew she would be doing great things for the CVS community. Without further delay, let's welcome Dr. Kovacic.
Thank you. Wonderful. Thank you so much, Debbie, for that. I will share my screen now. And I think you're all seeing me, correct? Okay. So I appreciate for this opportunity to talk today about some exciting research that's happening at the Medical College of Wisconsin, where's my institution. And I know you all want to hear about the latest, and that's what I'm going to tell you. So I will talk mostly about, really only about auricular neurostimulation, which is a novel therapy, and our current data in CVS. But my disclosures is that I am a consultant for Takeda Pharmaceuticals, but has no relation to this presentation. Otherwise, I have no other financial disclosures. So the objectives for today is to review the current data on auricular neurostimulation in pediatric functional abdominal pain disorders. I'm going to start with the background of how we began to venture into this novel therapy, and then some data on our plausible mechanisms for the therapeutic effects, and then the preliminary data in CVS. I will end with some Q&A, so I will give you plenty of time to ask questions because I know there will be many. So here's a little bit of the complexity of what's happening in many functional gastrointestinal disorders. There's brain to gut communication. There's multiple brain areas involved. And this particular slide kind of talks a little bit of what's involved in cyclic vomiting syndrome. You have multiple cortical, brain, and central nervous system inputs and triggers for the vomiting episodes. And there are migraine features in many patients, autonomic nervous system imbalance. There is strong triggers with anxiety, some with motion sickness. And these certain specific cortical brain regions are involved in triggering signals at the brain stem, nausea, and vomiting centers that are then carried down to the gastrointestinal tract. Debbie, can you see this part of the screen, or do you see yourself here? Is your video? Do I need to move?
No, I can see it.
See the stomach, right?
Yep, I see it.
So there's lots of brain to gut signaling going on, and this is mediated really by the vagus nerve signaling and the autonomic nervous system, and we're going to get more into that. Let's see. Can't move forward for some reason. All right, so for therapies for cyclic vomiting syndrome and other functional GI disorders, we use a variety of what we call neuromodulators. That is really just a global word for changing the neural circuitry here, and that could be with drugs, it could be with even lifestyle changes, neuromodulation, sort of alternative therapies, and cognitive behavioral therapy, anything that can influence these brain gut signals. We have anti-migraine and kind of straight brainstem drug targets with a novel treatment called Prepitant or Emend that is really very clean drug delivery. We use obviously broader antiemetics and antihistamines for treatments. And then sometimes we even use prokinetics, meaning we try to affect the functioning of the gut itself to help vomiting cycles. There's less data on efficacy for this in CVS, but it may help certain patients. There's some data from Iran that can be effective as well, although not so commonly used. Then we, for functional GI disorders broadly, we use stomach relaxants such as cipraheptadine, that's also an anti-migraine treatment, and then gastric electrical stimulation, which is not so applicable in my opinion to CVS, although we have some data on that too. Then the neurostimulation therapy really is affecting the brain gut signaling directly, and that is what we want. And we want a treatment that can do this non-invasively. So why are CVS episodes so disabling? I'm kind of preaching to the choir here about a lot of things that you already know, but it's really about this being a brain disorder, and it's just a problem with the signaling of the autonomic nervous system between the brain and the gut. And CVS is such a closely it's a disorder really of the brain and central and autonomic signaling that when you have aberrant brain gut signaling, and this is most severe of its sort, the manifestations are really, really severe. So treating CVS, as you know, we have several avenues, including lifestyle changes, mitochondrial supplements, and then we divide the treatment into prophylactic drugs and abortive drugs. For those of you who don't know, we often provide a very individualized treatment plan that includes all these aspects of the treatment. And if you're a candidate for prophylactic therapy, meaning that's controlling your cycles, if they're happening too frequently, then we use these drugs that you take on a daily basis. So that's prophylactic drugs. And then abortive drugs are more designed to kind of rescue, improve the symptoms when episodes are happening, and do everything we can to stop these disabling vomiting episodes and this cascade that's getting initiated from the brain. And it's so difficult to stop. Often includes sedatives and strong medications. So efficient drug delivery is a major problem. We use as much as we can now. We use creams. We have a Zofran cream at our center. We have nasal sprays that are anti-migraine agents. We do rectal treatments, but to put something in the mouth when you have this episode, and if it comes out of nowhere in the middle of the night, that's really a big problem, as many of you know. So as you can tell, I'm talking about drugs. And as you all are, I'm sure, we are, as providers, getting quite frustrated with this. And I've always had major concerns about the number of pharmacologic therapies that we are using, the polypharmacy you see in CVS patients. But this is what we have. And unfortunately, there is some effectiveness of the drugs, but many kids get put on so many things, and it's you know, and it's a risk benefit ratio there where you kind of have to, or you're having these cycles. Some kids are vomiting every week or every 2 weeks, and getting admitted to the hospital back to back. We also use emergency room treatment protocols, IV drugs, again, strong sedative medications. So I have been very interested in pharmacological therapies, and a few years back, we started looking at a way to do neuromodulation non-invasively. So there's already emerging therapies that are very exciting, and as far as different GI disorders and other pain conditions. There's spinal cord stimulation. We now use something called sacral neuromodulation for refractory defecation problems. This is quite interesting and an effective treatment, but invasive and implantable devices that go operated that gets put surgically into the lower back, the spine. There's deep brain stimulation that's even been used for adults with irritable bowel syndrome. Sounds pretty crazy, but this is reality. And then there's vagal nerve stimulation therapies. This is interesting, where this is a neurosurgery where you implant a stimulator directly on the left vagus nerve. And the vagus nerve is really a parasympathetic nervous system, part of the autonomic nervous system, that you can have incredible benefits, health benefits for many conditions if you're able to stimulate this nerve. Now this has been designed for treatment refractory epilepsy, but it's also FDA approved in adults for major depression. And in vagal nerve stimulation studies, they have incidentally noted that patients with migraine disorders, for example, improved. You may have elevated mood, improved energy. So if you can stimulate the vagus nerve, or do VNS, vagal nerve stimulation, that is an exciting area of medicine. So how could we target these central brain pathways non-invasively? So at our center, a few years back, we started using a little device. The only place where the vagus nerve actually hits the external body, the outside of the body, is the outer ear. There's multiple branches of the vagus nerve and some other cranial nerves. And this technique is called percutaneous electrical nerve field stimulation. So this targets central nervous system and autonomic nervous system. Those are intertwined by sending electrical impulses through the several cranial nerve branches on the outer ear. Here's one of the devices. This design has been improved, but this is from our first study at the Medical College of Wisconsin. So here on the left side, you see several of the nerves that we think we're stimulating. The trigeminal nerve, which is probably really a strong influence in migraine disorders, so the trigeminal vascular system. There's still lots of questions about what causes migraine, but this trigeminal nerve is thought to be involved. Facial nerve, the glossopharyngeal nerve, and then the big guy, vagus. There's something called the auricular branch of the vagus nerve that branches out to the ear, and then go into the nucleus tractus solitarius. That's the brainstem area that actually has the major nausea and vomiting centers. And in here, you have a relay station for this vagus nerve that really communicates with a lot of higher cortical centers, some what we call limbic brain regions. That's the amygdala is involved in stress reactions, emotions, memories, and we think a lot of signaling with the amygdala is involved, is actually connected to these vagal nerve pathways. This is very complicated, clearly, but I'm making it simple, and that if we then stimulate these pathways from the outer ear, we think we can actually influence these regions. And we actually have some data that amygdala signaling is suppressed with this particular device, and these are studies done in rats. So can we this way affect the gut sensations and nausea and vomiting signaling? Well, it certainly appears that way. So our first clinical trial that we performed was a 4-week trial, 5 days on with this device that you wear on the outer ear and 2 days off each week. So that's a little bit of kind of logistics. Wearing something with stickers and adhesives on the outer ear gets a little bothersome. So 5 days on, 2 days off is pretty reasonable before you start having itchiness and getting annoyed with this. But kids do really well. This is a 9-year-old boy, a nice little ear model. He's super cute, and he has no problems wearing it for multiple weeks in a row. So the first clinical trial, we did 4 weeks. This provides low voltage stimulation to the outer ear. nothing can happen. If you get it wet, it will inactivate, but this is a low voltage, very safe device that then provides different frequencies of stimulation and amplitudes, and it kind of cycles on and off. In this way, we think it actually does not saturate or tire out that vagus nerve. So contrary to common TENS unit that may be worn for like an hour per day for at home, which is nice, this device actually provides tissue penetration with little tiny pins. They're not really needles. We call them needles. Kids get kind of nervous about it, but it really doesn't hurt. It can hurt a little bit if you hit a nerve ending, but it's really not bad. And it's worn for 24/7 for 5 days. You can continue all normal activities. We've had football players, hockey players, horseback riders, anything. You cannot swim. That's the only thing you can't do. So we do anywhere from 4 to 8 weeks of therapy, sometimes even longer, and it depends on the clinical indication. The little rat on the right side there was part of the animal study. And again, this showed actually improvement. There's ways to measure sensitivities to gut distension in rats. These are very validated experiments that are done in animals. I'm not going to get into the details, but these rats were actually given colitis, which sounds pretty horrible. Sadly, a common experiment with rats, you give them colitis and they got put, the device got put on their ear for 5 days, and then they measure distension to colon and different ways, or paw pressure, these validated measures of how the rat responds. And these, what we call visceral hypersensitivities, improved in the rats. And in this study, also found suppression of amygdala and spinal cord neuronal signaling. So it actually has some animal evidence for improvement in these central nervous system brain regions, which is very exciting. Our first study in functional abdominal pain disorders was published in The Lancet, which is a big international journal. It's very exciting. This was a randomized double-blind clinical trial performed a few years back. It was sponsored by the American Neurogastroenterology and Motility Society, which is also exciting for us to get this backup, and has led to further studies and grant funding. So in this study, I'm going to review briefly what happened. 104 adolescents, teenagers, 11 to 18 years of age, with functional abdominal pain disorders. These include irritable bowel syndrome, functional abdominal pain, functional dyspepsia, and abdominal migraine, which is a variant of CVS. So there has some relevance to our patients that are listening today. It was a double-blind clinical trial. That means that both patients, participants, and researchers all involved are blinded to what the patient gets. So half of the patients got a fake device, a sham device that does not have the electrical stimulation, but otherwise was completely identical, and nobody knows. They underwent 4 weeks of therapy, again, active versus sham device, and outcomes. We looked at pain, well-being, and disability. We did not look at nausea and vomiting, unfortunately. After 3 weeks of treatment, we looked at these outcomes, and really should have done it after 4 weeks, but they were not returning to our hospital at that time. So then we followed them up 2 to 3 months later in clinics, and this is what we saw. So the FDA actually has set an improvement of 30% as a critical guideline as what is improvement. So you can improve by a little bit, and it doesn't, what is clinically meaningful. So according to FDA and adult irritable bowel syndrome trials, this is a gold standard criterion for measurements of improvement. So we looked at how many individuals had improvement greater than 30% in their pain levels after the 3 weeks of therapy, and in the treatment group, the active treatment group, in the gray bars, 60% actually improved, significantly better than in the sham group, where it was by 22%. And this was in their worst abdominal pain over the past week. Similar findings in the usual kind of average abdominal pain that they reported. So that's exciting. I see somebody I know here. Functional disability, which is a standardized instrument scored at objectively measure a child's functioning improved in this PENFS, or percutaneous electrical nerve field stimulation. It's a tongue twister, but I'm going to refer to it as PENFS therapy. They improved by about 36% on average, where there was no improvement in the sham group. And notably, this was at the follow-up time point. This was 2 to 3 months later. So one of the most common questions I get is, how long does it last? Well, based on this therapy, effects lasted for 2 to 3 months. That's a little bit arbitrary, because it can be confounded by other medications we could not control. We could not ask patients to hold other treatment interventions in that time period, but it's looking like it's having some lasting effects. And I always point out the very high complexity of the patients in this trial. The active treatment group had already failed 4 medications previously, and we're not talking about Zofran, we're talking about things like amitriptyline and true what's in CVS used as prophylactic drugs. In the sham group, there were 6 on average. Majority had not responded to medical therapy already. So we were not recruiting just simple irritable bowel syndrome patients. These are complex kids with functional GI disorders that come to this tertiary care center. One of the most important things I'd like to point out, that there are no serious adverse events to date. And we've been doing this for 5 years now. We have never had an infection. We've had some ears that turn red, and it's kind of sometimes looking like an infection, but it's really an allergic reaction. And that can certainly happen with these adhesives. Most of the time we can circumvent that. It's not a big deal. In the world of side effects, as you know, many of you are accustomed to drug side effects, and those are horrible. This is pretty minor. Some ear discomfort, we can tweak it. Adhesive allergies, cosmetic, and anxiety around wearing this thing in school. That's the biggest issue. I've learned a lot about teenage boys through these clinical trials. They're the ones that have the problem. Usually girls don't really care. They hide this thing, and it's all good. And younger boys have no problem. So I give them a hard time. Needle phobia can also happen because that is a concern with these little pins going into the skin. But we obviously identify these ahead of time. And I like to also say that in our first clinical trial, almost all of our dropouts and side effects and these little things happen in the first 20, 30 patients, when we really didn't know what we were doing either as far as education. So once you prepare families, it's really not a big deal. So only 10 patients reported some of these milder side effects, and we have yet to have any serious adverse reactions. And this is why I do this. So, and why I continue the studies, and why I continue to research this therapy and other similar neuromodulation treatments, is the patient satisfaction. Over 90%, 95% would recommend it afterwards to a family or friend. People love this. It's alternative medicine. It is clear that it's nothing invasive, and it's just wonderful to work with. If we could get insurance companies to buy into this a little quicker, that would be even better. But the FDA did, and after our sub-analysis of specific patients in our first clinical trial with irritable bowel syndrome, they approved this device for IBS. So it really has to do with most of the research in this area is done in adults with irritable bowel syndrome, and IBS is where the research happens. So now it's approved for 11 to 18 years of age, but that doesn't mean that you have automatic insurance approval, unfortunately, because you have to have a specific billing code tied to this, and that sometimes takes time. So I like to point out always that there's lots of migraine devices and transcranial and magnetic stimulation and all kinds of things that are very costly, but they're not approved. And that's really sad. So I continue to fight this battle. We'll talk a little bit more about it. So what about the mechanisms? So we have just released this article about a possible mechanism of this device. So we performed what's called heart rate variability studies, and that's looking at how the heart rate varies between the heartbeats. This is a little complicated, but a high variability of your heart rate is a good thing, and it's associated with health, whereas a low, in many studies, how to measure this can vary between different studies. This is work by one of the most esteemed neuroscientists in this field, Dr. Stephen Porges, and he does wonderful work in this field. He's kind of like the vagus nerve guy, and he has actually founded the polyvagal theory, and I urge you to read about him, and he's written books about the polyvagal theory because we continue to do research together And this theory really applies well to functional brain disorders or disorders of brain gut signaling, just like cyclic vomiting syndrome. So what we did is we did some simple EKGs before and after this therapy. And there's ways to then measure the vagal tone, the vagus nerve tone. And this is the parasympathetic nervous system. So that's part of your autonomic nervous system. That involves, as you may know, the sympathetic nervous system and the parasympathetic. They have to be in balance. And when you have a CVS episodes, they're completely out of whack, as I usually say. We can see clearly on patients that they're on the high sympathetic nervous system drive. Pupils are dilated, they're sweating, they're vomiting, they're nauseous. These patients are known to have an abnormality in their autonomic nervous system. But interestingly, there's now data from Sally Tarbell, CVS, one of our CVS medical advisors and gurus. She has published evidence, and others have as well, showing that the vagal tone is actually abnormal when they walk around normally, these cyclic vomiting patients. And these are studies done in children. So even at baseline, when they appear healthy, there's a little bit of a something wrong there with this autonomic nervous system. And perhaps that is enough to be, that's not enough to be sick on a day-to-day basis, but it's enough for that trigger, that infection or anxiety or school starting or lack of sleep, exhaustion, to set them off into a vomiting cycle. I think that makes a lot of sense to everybody who listens. So again, so this EKG can actually measure the vagal tone, but it's a little bit of a surrogate. It's a cardiac influence. It's a cardiac vagal tone. So it's a little bit of an extrapolation from what's happening in your GI tract, but we think it's a pretty good surrogate of your overall vagal tone in your body. And this actually kind of indicates the brainstem control of the heart. And we talk a lot about the vagal brake on the heart using these measures. And one measure that we have extrapolated from these heart rate variability studies is the vagal efficiency. And that's the effectiveness of this vagal brake in regulating heart rate during posture shifts. So these patients were put through different stressors, or just posture shift as stressors. And patients who, you may know, have dysautonomia, for example, which is a very related disorder. I can't get into all the details there, but they cannot cope with even posture shifts, and the heart rate goes abnormally high. So we found that patients who had a low vagal efficiency, and again, that kind of means that you have a poor way of adjusting to bodily stressors, and probably cyclic vomiting patients have that, but that's kind of a guess and extrapolation for me. We haven't really looked at this in detail yet, but that is coming soon. This low vagal efficiency, so if you have a low vagal tone and a poor way of responding to these postural stressors, and perhaps other stressors, other things that disrupt your homeostasis. How about a meal ingestion? How about any stressors externally or in the family? And those you could see as potentially being triggers of these gut symptoms. So patients with low vagal efficiency actually did the best with this therapy. So changing the vagus nerve signaling is a very plausible mechanism of the therapeutic effect. So in summary, we seem to be doing something that modulates the vagus nerve, because there are a specific subset of patients that do particularly well and had the greatest improvement in their pain. So more to come on this, because we are now doing similar measurements in CVS patients, and its data is really cooking and finishing up shortly. So I'm going to get into that and what we have for CVS. So this is the research we're currently doing. We have a multi-centered clinical registry. I think one of our doctors is listening here, Dr. El Chamaz from Cincinnati Children's. He is part of this. And multiple other centers are joining. As you can see, big centers across the country are taking part of the clinical registry. We're just capturing data on patients who get this therapy. And that's one of the best ways and really showing that, is this therapy working or not, or is there placebo effects? Most likely, like any therapy, there could be serious placebo effects, but we're trying to look if this works at many hundreds and many sites, and that's the point of this registry. And we have more sites joining as well. So I also have an NIH-funded clinical trial that involves neuromodulation with the same device and characterization of patients who suffer from chronic nausea. That's a little bit related to cyclic vomiting because we see a lot of patients who evolve from a history of cyclic vomiting into chronic nausea and autonomic nervous system dysfunction. So we are looking at about 100 patients with chronic nausea, and we are phenotyping them. We're doing a lot of testing to them and clinical and physiologic characterization, and then they go through the therapy. And then we have run a pilot study of PENFS for cyclic vomiting syndrome. I'll show you some of the results, and then also some of the mechanistic studies I mentioned. So in the cyclic vomiting pilot study, we have now, we started with the rescue therapy, thinking that if you catch patients in the prodrome, meaning that they're starting their episodes, have some irritability and symptoms of the episode coming, classically, it's thought that many patients have up to 24 hours of prodromal symptoms. In reality, so many just wake up in the middle of the night and it's 3 a.m. and they have a 50-minute window and then they're vomiting. So how do you do this in reality when you have to bring them into the hospital and place a device on them? So this didn't go that well. We enrolled both children and adults, and the best candidates are the patients who have calendar time CVS, when there's predictable episodes and some families know it's happening on this day and we will place the device on that day. And some have done really well, but these patients are actually pretty far between, few and far between. It's not that common, especially in adults. So we really have adults who suffer from CVS. It was shocking to learn how many they don't have a spouse, they don't have a job, they can't get, they're suffering in their home. They can't get here when they're having an episode. So we tried our best, but it was not easy. So I kind of changed the course, and I changed the trial to a prophylactic treatment. And that's why I wanted to mention how we treat CVS. You treat it as rescue or you treat it as prophylactic. But ideally, the best treatment would be to undergo how many weeks of this treatment, and if it had lasting effects, that would be ideal. So that's what I wanted to test out. We have enrolled 30 patients in this prophylactic treatment arm. They undergo 6 weeks of PENFS therapy, and they're about between 16 and 18 years of age. We started with a little older and then have cut the limits a little bit. We noticed over time that so many younger kids with CVS or any younger kids really tolerate this treatment quite well, as long as they don't have anxiety with it. We have young kids coming in with the little doll with the with the device on their ear, and they really actually like it. And I want to point out that these patients have drug refractory CVS, so they're just not 30 kids with mild CVS walking around. No, they have failed drugs and they have cycles at least every 4 weeks. So this is complicated CVS. And the reason being, we provide 6 weeks of treatment, so we have to be able to measure if they're improving or not. So we kind of have to enroll patients who are a little bit more difficult. We do also the vagal tone measurements before and after. And this data we haven't looked at yet, but that's coming pretty soon. And this is a girl in our treatment, in our CVS trial. She's fairly young. And like I said, many young kids are tolerating it. This is a little girl from Atlanta area, and her mom has provided this wonderful summary of the treatment response. And I love this testimony, and I like to read it out to you guys. Ever had food poisoning, the worst one, the one worse than a stomach bug? Remember how you projectile vomited over and over again long after your stomach was empty? Remember the pain, the cramps, the extreme nausea, the dire need to drink due to severe dehydration, but as soon as an ice cube touched your lips, you vomited, and even though there was nothing to eliminate. Did you, sorry, I can see everything. Did you end up doubled over in pain on the floor, unable to move, while simultaneously vomiting violently in a rapid fire manner? This sounds like Dr. Lee talking, actually. He always says rapid fire vomiting. So sad, right? And I know that you all know this, but it's a touchy story. Well, my daughter has those symptoms, not for 6 to 8 hours, but for days on end. Have you ever had a migraine, just migraines in her abdomen and head until the episode ends in her state of complete exhaustion? When she wants to pass out, she gets bursts of pain in the frontal cortex like a seizure, which forces her to to stay awake unless I give her pain pills to knock her out. In her case, she also experiences severe dizziness for days after nausea, pain, vomiting, and migraines. The episodes end, and she returns to the most vibrant, joyful spirits of 10-year-old until another 69 days. So, a very typical case of calendar time CVS. As you all know, this is a common story, and it's so disabling. It's so difficult to get some people to understand the disabling nature of CVS if they don't experience it. So we intervened in this girl. We placed it because of the calendar time CVS. She was, in fact, our first patient, and it worked beautifully. Once the stimulator was installed, she was nausea-free, vomit-free, pain-free. At night, when the vomiting is usually the worst, she had no symptoms. Instead, she slept uninterrupted for 12 hours. She had 0 pain, nausea on a scale of 1 to 10. She didn't vomit one time. It was a miracle, and we were thankful, yada, yada, yada. Okay, so why I like to bring this testimony up too is that a lot of people talk about, well, it's just a placebo, might just be a placebo effect. You're putting this magical thing on the ear. Well, here you have a child who vomits every 70 days and there's nothing that can stop it. And there is the brain clock that has been set to do this, right? And tried all kinds of drugs. And, you know, when you talk to these families, there's no trigger. It just happens. The brain has decided it. And this is why I do think that we are providing neuromodulation. It's probably not going to work in everybody. Of course, nothing does. But if you can perhaps tweak the therapy, change the parameters of stimulation, modulate it, perhaps you really could improve many, many patients. So that is kind of the future. Now we just have one setting on one device. But I think this is really an emerging treatment that can make a true difference in CVS. So that's kind of how I feel about what may be coming. I could be wrong, but I think this is certainly really, really encouraging. In our interim analysis, that means that we took a peek. Our statisticians looked at the first 18. And we're presenting this data as well at a conference because we're so excited to disseminate this. 65% reported global improvement. And that's a good deal better. Remember, patients who vomit every 4 weeks, nothing has worked. 65% is saying that they're a good deal better after this simple 6-week intervention. So I'm impressed. And I think that those first 18, the 30 is going to show just the same. It's looking pretty remarkable. Mean nausea, abdominal pain, and headache intensity scores have decreased significantly at week 6. And analysis of sleep, daily vomiting surveys. We have everything on these patients. We made them go through a lot of assessments and surveys. Episode frequency and these vagal tone measures, all of that is pending. Obviously, the key is going to be figuring out how did the episodes really change. During those 6 weeks of therapy, I can tell you that so many actually did not vomit. Some had some cycles, but then it also frequently were less severe, less intense, shorter in duration if it happened. Some did not respond, but actually majority did. So here is a graph for how the functional disability inventory has dramatically improved in the first 18 patients from baseline to end of therapy. These are significant improvements in this scale. So I know there'll be questions. One more thing I'd like to point out that I'm 100% sure that you will ask me is that how long does it last and does it last? I don't know yet. We're following these patients, but it appears that the 6 weeks of treatment intervention has some lasting effects. And I think on average about 2 to 3 months, kids are staying quite episode free. Some do return, but when you respond, it really seems to be lasting. And I think some are lasting even longer. But even if it's somewhat impractical to come into the hospital to get this treatment, and of course, insurance reimbursement is a huge headache for us. If you can get an alternative medicine therapy that you do every 3-4 months and you do like a 4-week cycle of it, if it's close to your house, that's something that is quite incredible and most people would probably do in order to avoid drugs. So that's our goal to figure out. So this is our other chronic nausea trial, and I just want to mention what we're doing. It's an NIH funded, it's a large trial. We're doing 8 weeks of therapy, but the first 4 weeks are either placebo, a fake one, or a real one. And we're looking at multiple measures of brain gut physiology before and after treatment. We're looking at gastric emptying, a satiety drink test. We're looking at vagal function. We're looking at functional MRI, and a bunch of other things. And we have 73 patients enrolled to date, and we probably will finish this in the next few months. So in summary, PENFS is effective for a variety of complex functional abdominal pain disorder, and it's now FDA approved based on this research for irritable bowel syndrome, ages 11 to 18. Patients with abnormal vagal tone respond particularly well to this novel and non-invasive therapy. And our ongoing research suggests promising effects of vomiting pathways. And what I didn't mention is that the whole idea of using this in cyclic vomiting syndrome really came from clinical observations in our first trial, where there was patients who have comorbidities of nausea and vomiting, and many reported that that was improving. And then as I showed you the physiology on how we probably stimulating the vagus nerve and what's happening in cyclic vomiting syndrome with the autonomic nervous system abnormalities, it makes complete sense that that this should be done for cyclic vomiting. So I had this thought for a long time of looking at CVS with this therapy, and luckily CVS Association also sponsored this clinical trial. So with that, I will end that there is promising data in pediatric CVS, and I will promise that it's coming soon. Do my best to get this analyzed and published, because that's important for obviously for broadening this and getting insurance coverage and providing it to more families. So I will stop sharing my screen. Yes, Debbie?
Yeah, that's perfect.
I can mute myself.
Yes, no, don't mute yourself. We want to hear you. So I'll ask you the questions that we've gotten in the chat box, and then we will be excited to hear your answers. Thank you very much, by the way. That was awesome, and it's so exciting to hear about non-drug type studies that are happening for CVS patients. First question is, any plans for the neurostimulation to be available in other countries like Europe, Canada, are the specifics that I've been asked?
Well, I don't own this therapy and I don't control that, but I do get that question a lot. And that's not so simple, because like in Europe, for example, there's a EMA, EM marking is similar to an FDA, and you have to go through all these controlled agencies, and to market a device in Europe is a little bit problematic. So you can't just take it there and start it. So that is something you may want to turn to the distributing company, which is Innovative Health Solutions, with those questions. And I don't know that, but unfortunately, I assume that that's a little ways away. I know there's lots of Europeans interested in this. I've been contacted with many doctors. So the interest is there. Logistically, when it's going to happen, I don't know.
Great. And what about being available in adults? Are there any current studies in adults? Or
yeah, I get that question a lot as well. So our center at Adult Furthered Hospital here at Medical College of Wisconsin has been providing it through Tangam Venkatesan, which is our adult cyclic vomiting expert. And I think there's been a little bit difficulty with logistics and insurance reimbursement there as well. So I would perhaps try to reach out to her, but I think it is not that widely distributed in adults, and perhaps something that the company could give it more information about. I know there is adult irritable bowel syndrome trials happening on the West Coast already. So it's coming. I just don't have a lot of tips about go there, go here, and get it. But this is coming, I'm sure.
Yeah, well, and unfortunately, it seems like with all the COVID stuff, some of those trials are kind of being delayed. So
yes,
that's something else I think for people to keep in mind. And what about younger children? Because the study that you're doing is, what's the age range again?
So we lowered it. We are ending the CVS trial now, unfortunately. hopefully we don't get a storm of patients after this webinar. We had to end it because we don't have more funding for it. But so I've done it down to age 5. It's possible with a cooperative child, but a 2 or 3-year-old is not going to keep this on their ear. They're going to go pew.
Yeah.
So I think 5, 6 is doable if in a cooperative child, and every parent knows probably what their child can do. I think we just don't have the clinical trials there, but we've done it in our CS child down to age 7. Actually, is the lowest that we did. We haven't enrolled a 6-year-old, although we are allowed to.
Okay, great, thank you. We had a few people in the chat box asking about 2 and 3-year-olds, and your statement about the child pulling it off, I think, is a perfect answer to that. This question is, my daughter has been diagnosed with both GRE1 malformation and CVS. Is there a connection between the 2 of those? And if yes, what kind of doctor should we see to look into that possible connection?
GRE malformation is somewhat common. There's a lowering of the tonsil or the brainstem, and neurosurgery and surgery handles these problems. Usually those are not requiring surgeries. I'm a GI doctor, so I'm not going to venture into this too much, but a neurologist is the primary one to handle it. Interestingly, there is a close connection between Chiari malformation and connective tissue disorders, such as Ehlers-Danlos syndrome. So that's something to look out for. This was a younger child, though.
I don't know if she.
You don't know. Yeah. So connective tissue disorders is strongly linked to functional GI disorders, and we do see a number of cyclic vomiting patients who have Ehlers-Danlos syndrome, and we are starting to look at this too in our clinical trials. So I believe that if it's an older child, more over 7 or 8, you have to have a certain age before you can diagnose a connective tissue disorder. Those are patients who, it's a long story, hyperflexible joints, joint pains, musculoskeletal problems, but a variety of nausea and vomiting and functional GI disorders. So this patient may need to look into hypermobility disorders, but that's just a guess. There's a link there. I don't know of a direct link between Chiari and CVS, but just because there's a link between those 3, something to think about.
Mm-hmm, for sure.
If there's true proper pressure on the brainstem, though, then that can be dealt with surgically, and that could cause vomiting. So that needs to really be evaluated by neurosurgery and surgeons and neurology.
Okay, great, thank you. The device, could it be used to screen patients to see the response and later implant vagal neuros, like to have an implanted device?
Yeah, that's something that we think about as we're sitting in our living rooms, but once you go into the real medical world and try to get a vagal nerve stimulator implanted in your child, it's not medically indicated unless you have refractory seizures, so you're not going to get that. And not at this time, unless you have refractory seizures, and that's indicated. So you will not have a neurosurgeon implanting a device unless it's, officially indicated. So it's a great idea, and I know Dr. Lee and I have shared patients who have had vagal nerve stimulators implanted. A couple. I mean, this is not that we have many, but we have seen for epilepsy, of course, that when settings have been increased, there are kids who had a couple who had vomiting stop, for the CVS vomiting stop. So that is very interesting, and yes, in theory, a very good idea. In practice, unfortunately, we're not there yet.
Are there any providers that you know of offering this therapy to adults for IBS?
Right. So there's clinical trials happen, at least one that I know of, but again, maybe contact Innovative Health Solutions, the company, to see where there might be, because I do think that there are some adult providers that have shown interest. I just don't know if they've started in clinical practice, but I know there are some ongoing trials in adult IBS, yes.
Great. Is the Sato variant in CVS a sign of poor vagal tone?
Very good question. Probably interrelated, but we don't know for sure. The Sato variant is a dysregulation of the hypothalamic pituitary adrenal axis, which is a plausible mechanism in a subset of CVS patients. We need more studies to figure out what's happening in these patients, but those pathways that they have abnormalities in, this is SAUTO patients. Yes, I think they're probably linked to the vagus and vagal nervous system and autonomic signaling. I'm quite certain, but something we don't know. And I can't say, I think we've had 1 or 2 SAUTO subtype patients in our clinical trial, and I can think of one that did quite well. But I don't think this sample of 30 patients is enough to say, you know, this is going to help SAUTO. We need more data on a bigger clinical trial, which I hope to do next.
Great. Always need more data, right?
Yeah.
How is low vagal efficiency measured?
Okay, so it's a metric. It's a little a physiologic metric that's extrapolated from an EKG. So it's a very simple EKG leads on your chest, looking at the heart rate variability, but very sophisticated methods and analysis and cleaning of this data that only this Dr. Porges and his laboratory is doing. So you can't go out on the street and buy a machine that measures it. It's a neuroscientist that is doing these research methods.
Okay. Is it possible that the vagus nerve could be irritated during a heart surgery, in turn then causing her CVS?
Yeah, I think that we talk about vagal neuropathy, and that's kind of a nerve dysfunction of the vagus nerve that can happen with cardiac surgeries, quite well known, and quite well known as a consequence of fundoplication surgeries as well, which is wrapping the stomach. So these can cause vagal nerve damage, and it's there's just no way of knowing, you know, if your stomach emptying got worse, for example, after the vagus nerve handles stomach emptying as well, and you have a lot of nausea, vomiting problems, and yeah, CVS, it's possible, but there's no way for us to say that it was directly happening. But if it started after surgery, all well intended, that can be an effective surgery.
Okay, that's something that I just learned. So someone asked about who's eligible, and I think you went over this a bit in your talk, but maybe it wasn't quite clear. So are you only enrolling kids that are calendar kids, or are you doing other complicated cases as well?
No, initially when we used it as a rescue treatment, we were trying to find calendar kids, because then we could at least figure out when they were needed to come in. It was just not easy, and many of the kids I see are from Alabama and Arkansas, and I can't get them here, you know, next week. But so we then enrolled anybody with CVS that are frequent every 4 to 6 weeks of cycles. But we are finishing the trial. I know there's going to be more trials, and it's done in clinical care. So we have patients who come into the clinics after they did the research trial because they know it worked for them, and they come back and their insurance is covering this therapy, and quite often. But that's a little, there's no guarantees of that. And in some programs, they now have better luck with insurance coverage, and depends on your insurance, but you can potentially get it covered being a CVS patient. You don't necessarily have to have irritable bowel syndrome.
Great. Let's see. Is there a way to strengthen the vagus nerve?
A lot of these alternative modes of therapy, like CBT, cognitive behavioral therapy, hypnosis, exercise is thought to strengthen the vagus nerve. People who exercise a lot are, there's plenty of data showing that athletes have a greater heart rate variability and a greater vagal nerve strength, whereas deceased states, being disabled and sick, have lower vagus tone. So yeah, there are ways, and you may know, many of you that who potentially patients, or that you know, or you may know about POTS, autonomic dysfunction, dysautonomia. Our primary recommendation is actually exercise, lifestyle changes, drink water, exercise, sleep hygiene, and that's for CVS too, actually. So it works. People don't believe us when we say that, but exercise does a lot. And all this biofeedback, hypnosis, anything that calms your system actually can strengthen your vagal tone.
Yeah, makes perfect
So we're
sense.
not just saying, we're not saying that your child is a psychological mess or anxious. Like, yes, they are a little bit more anxious because they have these disorders, but there's true data behind seeing a psychologist and working on these things and really improving the vagal tone this is physiologic data.
Yeah, that's amazing. Let's see. I think that going back to when you were trying to do your study with the calendar kids, when you would catch them when you would try to catch them in the prodrome phase, had you ever been able to stop an episode?
Yes.
With that study?
Yeah, I think what's striking me is some adults, there was a mom with CVS that told me once, and I think many of you would agree, once the brain gets to a point where this cascade of vomiting starts, there's sort of nothing that can stop it. And I think that the device doesn't work once you get to that point. But if you catch it early, you can intervene and you can get better. We just don't have a lot of examples of it. We just couldn't catch them that early. And sometimes they were in full-blown vomiting and it's sort of too late. So I do think that it can be effective if you can do it. But we were limited to Monday through Friday business hours of doing this research as well. So that's the hard part.
For sure. Let's see.
Some people are asking about the duration of therapy still, and that's the most common question I get. Yeah. So my guesstimation here is about 2 to 3 months of an effect, at least when you have a response, but it's a little bit all over the place. And we have a few kids in our patients with IBS or chronic nausea that as soon as the device comes off, they're worse again. And I can't explain that. Sometimes I wonder if those patients have more placebo effects. But that is not so common. So when it works, it tends to last several months. And we have longer. We've seen patients last for a year and not even come back to us, which is wonderful.
Yeah, that is wonderful. All right. One last question. Can the vagal nerve be damaged by a virus like Epstein-Barr?
Yeah, probably. We have a lot of disorders in our GI tract, gastroparesis or stomach emptying delays, IBS, that are called post-infectious. I don't think we necessarily see CBS starting after an infection, but dysautonomia also does. So we talk about post-infectious functional GI disorders all the time, and that's very commonly described. We just don't have proof that it actually affects the vagus nerve. But very likely, if you ask me, it's what these viruses can do. The viruses can be very nasty, and EBV viruses is particularly a common trigger of things like dysautonomia.
Makes sense. Well, thank you very much, Dr. Kovacic. This was definitely enlightening, I think, for many, and I think a lot of people will be looking to see when it's available in adults and in other countries and things like that. So I'm sure IHS will be getting some emails today.
My nurse will get mad at you all.
And of course, we as an organization try to keep everybody updated as much as we can about when the studies are happening and things like that.
Yeah, so. I'm joking. We love to help when we can. It's hard because we don't have answers to a lot of questions like, I get this for sure covered and how long does it last and can I get it tomorrow? So, but stay put. I think that this is really, really exciting therapies on the horizon. So hopefully my goal is that this can be modulated and designed to be more feasible for patients, more individualized therapies, to have more patients respond to it and and more coverage to be able to avoid hospitalizations. Long term, it's going to be cost effective.
Yeah, for sure. Oh, IHS gave the phone number in the chat. If oh no, I'm sorry, someone else gave their phone number, but that will be helpful to many.
You know that.
Again, thank you everybody for joining us today, and we look forward to seeing everybody next month.
Thank you.